is a case of end-stage renal disease with struggling with severe anemia. So she's a 13-year girl child diagnosed as a end-stage renal disease at age of 9 years in 2017, and she was put on dialysis, hemolysis on December 2017. But after the diagnosis, she left our unit and then moving around different center around the India, including some government and private hospital. But she came back to our unit April 2020, about 1 year ago. So at that time, she has sepsis, including systemic fungal infection and severe cardiac dysfunction in the form of dilated cardiomyopathy with left ventricular dysfunction with ejection fraction of 16%. So we now focus our anemia. So when she came back, our hemoglobin was 6.2, and other cell line like white cell count was a bit high, 22,000. Platelet count was 2.6 lakhs. So we do workup for her causes of anemia. So iron study revealed ferritin is very high, around 2900, and transferrin saturation was 40%. And peripheral smear shows pneumocytic pneumochromic anemia. Other hemolytic workup also revealed that direct test was negative, reticulocyte count about 0.6%, and parathormone like 1650 picogram. So she was erythropoietin 4,000 unit per week, about 220 unit per kg per week, and she was also iron 5 mg per kg per day. So at present, she has some comorbidities, like although she be to improve her cardiac function, but still she has cardiomyopathy with left ventricular dysfunction and left ventricular ejection fraction of now 42%. So she which improved from 16% to 42%. She has got sensorineural hearing loss, and she has seizure disorder, but it's controlled with medicine right now. So I'm just trying to summarize here. It's a very busy slide. So over the last 1 year, what we did, what able to manage her. So when she came back here, she was 30 years, but her weight was about 16 kg, and hemoglobin was 6.2. So she need transfusion once, about 3 transfusions in a month to reach the normal hemoglobin level. As per history-wise, she used to get transfusion once or once a month from other center. So then we find out her cardiac dysfunction. So we stabilize her dialysis modality because her ejection fraction was very low. So she not able to tolerate dialysis, 3 hours, 4 hours of dialysis. So we did around 2 hours, 2.5 hours of dialysis. Sometimes we did very slow slate dialysis also. So initially we used to do daily dialysis, and then subsequently when the cardiac function improved, we increase the frequency of frequency of dialysis from 6 per week to 5 per week. Currently, she's on 4 dialysis per week. So you can see hemoglobin level is just fluctuating, and she most of the time needs once a month transfusion. So as her cardiac function improve and able to good dialysis, we can see the transfusion frequency is coming down. And she got last transfusion in December. Till now, about 3 months, she able to maintain at least hemoglobin level of 8 to 9 milligram per deciliter. We also increase her erythropoietin level from 4,000 per week to right now around 8,000 per week. She also has other problem like high parathormone level. This is a bit an uncontrolled kind of parathormone level to 1650, but we modify most of the agent so that she has now parathormone level of around 400 to 500 range. So iron study since beginning, her ferritin is very high, like super high, around 2900 to right now around 22 50. So it could be due to chronic inflammation. We did some inflammatory workup, but it's not, nothing is positive right now. So other cell line like total leukocyte count, platelet count are in the normal range. So we also look for other causes of anemia. So we did stool for blood that was negative. So thyroid profile that also reveal normal, and the vitamin B12 level that is very high because we gave mega dose of vitamin B12 and folic acid. And the coagulation profile that was also normal, and the hemolytic workup I did mention earlier that also normal. There is no gross blood loss in the form of GI blood loss from the gastrointestinal tract or from vomiters or from the other body parts. And also we used to check her hemodialyzer. There is no major clot or there is no blood leak to the dialyzer. Ultimately, we discussed with the hematologist. It could be other causes of hematological causes of anemia, and also there is a high PTH, so that could be affecting the bone marrow. So we ultimately did a bone marrow aspiration and biopsy that revealed normocellular marrow with normoblastic hyperplasia. So actually, currently what we did, currently she's doing a bit better than the previously she came back. So I'm just summarizing this brief case presentation. She's just her picture. She's holding her drawing on March 11, 2021, the World Kidney Day. Thank you so much.
Thank you, Subankar. So I think we will straight away go to Suzanne's talk, and then we can come back to your main slide, and like Suzanne can then tell or discuss about this child at the last. So Suzanne, if you are okay with this plan.
Sorry. Yes, I'm still not that good with all the IT. Takes me a while to unmute myself. Right. So good afternoon, everybody. Or it's actually good evening, isn't it, everybody, for you? So thank you for inviting me. Apparently my thing's not working. It's not going to let. Oh, yeah, we are. So I'm a paediatric nephrologist. I work at Birmingham Women's and Children's Hospital in the UK, and I've been there for about 19 years. Before that, I trained in London, mostly at Evelina at Guy's, and then at Great Ormond Street for a year. I'm currently the hemodialysis lead for our unit. I do have an interest in renal anemia, and I have done since about 2004. I started doing unit guidelines, introduced the use of IV iron in our unit, and things like that. And then about 5 years ago, I was invited to join the guideline development group for the anemia of chronic kidney disease on the NICE guidance committee. Those are my only claims of fame, so I'm not a huge world expert. So what am I going to say? I'm going to talk a little bit using the NICE and KDIGO guidance. I'll talk to you about what renal anemia is, a bit about history of renal anemia, about diagnosis and assessment, treatment, and some things for the future, not necessarily in that order. So first of all, what's NICE? So NICE is the National Institute for Health, Care and Excellence in the UK. It was created in 1999, and over the years it's evolved. It's there to balance the needs to achieve the most overall benefit for the greatest number of people. So obviously in the UK we have the National Health Service, which has limited funds. So we need to ensure fairness and we need to respect the individual choice. Its remit is not only health, but also public health and social care. The committee members on the guidelines are selected for knowledge and experience. They're in their own right, and they don't usually represent the organisation they work in. The guidance and standards are underpinned by evidence, and I would say as far as possible. Obviously in paediatric nephrology, we don't always have evidence for everything that we do. And the other thing that I've used to try and to do this talk for you is KDIGO, which I'm sure you're all familiar with, kidney disease improving global outcomes. So they state that their mission is to improve care and outcomes of patients with kidney disease worldwide through the development and implementation of global clinical practice guidelines. So what is anemia? I mean, we all know what anemia is, don't we? It's defined as a state in which the quality or quantity of circulating red blood cells is below normal. And the key indicator that we use is the blood hemoglobin level. Its pathogenesis is often multifactorial. And the anemia of renal disease is a hypoproliferative anemia, usually due to erythropoietin deficiency with a tendency to be normochromic and normocytic. So the mechanisms of anemia of chronic disease, this is just a pictorial showing of it. So obviously the kidney, you have decreased production of erythropoietin, which is there to act on the bone marrow to produce red blood cells. Obviously, to be able to do that, you need adequate iron stores, and that can be an issue with absorption from the gut. And we'll talk a bit more about iron in a minute. And the liver produces hepcidin, which is usually excreted through the kidney and can build up. And we'll talk a bit about more hepcidin in a minute as well. So iron deficiency can be either true, where you have reduced or absent iron stores. In renal disease, you have obviously more blood loss in your dialysis lines in hemodialysis. Our patients have quite a lot of phlebotomy. They often have very poor diet and sometimes have gut losses as well. And also functional iron deficiency, where you have a normal or increased store which is unavailable to incorporate into the erythropoietin cells, mainly due to the increased levels of hepcidin, which reduce the ability to recruit iron from the reticular endothelial cells and hepatocytes. Hepcidin is a small peptide hormone which is produced by the liver, and it prevents iron transport by binding to the iron transporter ferroport, which is located on the basal membrane of the enterocytes, reticulocytes, and hepatocytes, and it internalizes into the cell. The ferroport gets degraded in it, and as I said, hepcidin's increased in renal disease, which is not ideal. So what are the effects of anemia in children? This is taken from many papers, but essentially tissue hypoxia, cardiac causes or cardiac effects, hypertension, left ventricular dysfunction, left ventricular hypertrophy, heart failure. So with your girl that you presented, I guess it could be part of the cause of her heart disease added to the hypertension and possible other causes as well. Reduced exercise capacity, important particularly for children, reduced cognition and concentration, so difficulty with learning. These children often have reduced linear growth as well. Anemia in children and adults is an independent risk factor too for the progression of CKD. These children have a reduced immune responsiveness and often a reduced quality of life, and it's also a risk factor for death. So when to investigate for anemia of chronic disease. So this is from the NICE 2015 guidance, and it states that an estimated glomerular filtration rate of less than 60 should trigger investigation into whether anemia is due to CKD. When the eGFR is greater than or equal than 60, the anemia is more likely to be related to other causes. It states that you should consider investigating and managing people with chronic kidney disease if the hemoglobin level falls to less than 110 or 105 for children less than 2. So in other words, don't wait until your child is anemic before you start initiating medicine treatment, or if they develop symptoms which are attributable to anemia, such as tiredness, shortness of breath, lethargy, etc. So KDIGO tells us that, and these are guidelines from 2012, so these are quite old now. In patients with CKD and anemia, regardless of age and CKD stage, you should include the following tests. So a complete or full blood count, including the hemoglobin concentration, red cell indices, white blood count, differential platelet count, and absolute reticulocyte count, serum ferritin and serum transferrin saturation or percentage iron saturation, also vitamin B12 and folate levels. So this is from NICE now. Sorry, this bit's very boring. Carry out and testing and diagnose iron deficiency and determine the potential responsiveness to iron therapy and long-term iron requirements every 3 months or every 1 to 3 months for patients receiving hemodialysis. They suggest that you use hypochromic red cells. So a percentage hypochromic red cell of more than 6% would suggest that you have iron deficiency anemia. You have to be able to process that within 6 hours though. And our labs do actually do the hypochromic red cells, but they don't report them for us because they say they're not actually accredited to be reported. So although we have that capacity, we're not using hypochromic red cells still. This is our aim, but we're still not doing it. And they then say that if you can't use hypochromic red cells, to use reticulocyte hemoglobin with a content of less than 29 pg being suggestive of iron deficiency. And again, although we have those, they don't report them, so we can't use them. So we still use iron saturation and ferritin in combination. So it says if these tests are not available, or if the person has thalassemia or thalassemia traits, then we should be using a combination of transferrin saturation and ferritin, obviously ensuring that your CRP is normal so that your ferritin as an acute phase reactant isn't falsely elevated, and basically treating levels of less than 100 or iron saturations of less than 20. And it states categorically not to request transferrin saturation or ferritin alone to use as a guide of iron deficiency. You should use both in combination. So the NICE guidance also says that we should be doing B12 and folate, and they also suggest doing tests for hemolysis, including haptoglobin, LDH, etc. And they also suggest we should be doing hemoglobin electrophoresis. So what about treatment options? I think the 3 main treatment options we would talk about would be treatment with iron, erythropoietin stimulating agents, ESAs or EPO, or transfusions. So what are the optimal hemoglobin levels? Well, we'll talk a bit more as we go through the talk about this, but essentially we wouldn't be aiming to correct the hemoglobin to normal ranges with EPO. Typically the aspirational range, and this is from NICE, but the levels are similar with KDIGO, I think, is to maintain the hemoglobin between 100 and 120 grams per litre for adults, young people and children over the age of 2, and for those between under the age of 2, between 95 and 115. Which reflects the lower normal range in that age group. We should be keeping the hemoglobin within the aspirational range, but not waiting until the hemoglobin is outside the aspirational range before we adjust the treatment. So if your hemoglobin is, say, 105, 104, rather than waiting for it to drop down into the 90s to do your increase before that, and likewise if your hemoglobin is more like 115, to be thinking about whether or not you should be reducing your erythropoietin. So NICE says that we should be offering iron therapy to patients with anemia of chronic disease who are iron deficient, who are not receiving EPO, before we think about prescribing EPO to them. That we need to talk about risks and benefit of treatment options and take into account the person's choice. And this is very much a theme throughout NICE, is that we should take into account the person's choice. For people who are not on hemodialysis, we should be thinking about using oral iron before we think about giving IV iron. If they're intolerant of oral iron, or we don't get to a target hemoglobin level within 3 months, then we should be offering IV iron to all our patients. And for those who are receiving hemodialysis, we offer IV iron to all of those children. If they refuse it, if they have side effects, if it's contraindicated for any reason, then we would offer oral iron. But to be honest, I think none of my hemodialysis patients are on oral iron, they're all on IV. And then for those patients on erythropoietin stimulating agents, iron, we should be offering iron to people with anemia of chronic disease who are iron deficient and receiving ESA therapy, talking about risks and benefits, and again taking into account people's choices. For adults and young people, they suggest offering intravenous iron. For children who are on hemodialysis, offering intravenous iron. But for children who are not on hemodialysis, using oral iron unless children are intolerant of it, or unless we're not achieving target hemoglobin ranges within 3 months. This is more now for adults, but they talk about using high dose, low frequency iron. We tend to use lower doses for the children and give it more frequently, but you could argue that perhaps not that cost effective or that kind to the children, who then have to have more cannulas and things. So KDIGO says about iron that all pediatric CKD patients who are not on iron or ESAs, they recommend, with anemia, should all be given oral iron unless they're hemodialysis patients. So very similar when the T saturation is less than 20 or the ferritin is less than 100. And then for all pediatric CKD patients on EPO who are not receiving iron, they recommend iron oral if they're not hemodialysis, but IV if they're on hemodialysis. We all know about the side effects of iron. For oral, it's mostly GI side effects. For IV, obviously the most serious is an anaphylaxis, but commonly occurring effects include dizziness, flushing, headaches, hypertension, hypophosphatemia. Can't say I have that problem with any of my patients, or certainly many. Nausea, skin reactions, and altered taste, which they do quite often complain of. So monitoring iron status during treatment, this is from NICE. Essentially, it talks about keeping the levels above the ranges that we've already mentioned, but aiming to keep the ferritin less than 800. They talk about measuring iron status every 1 to 3 months in people on hemodialysis. We certainly measure ours monthly. And if patients are pre-dialysis or on PD, monitoring every 3 months. They do state that if people have a normal full blood count, there's probably little benefit in checking iron status. So this is a spot audit. This is from my hemodialysis patients this month. And just out of interest, I looked at my dose of darbepoetin compared to the patient's ferritins, and you can see we have gone over slightly with a couple of them, but you can see there's a inverse correlation. So the higher your dose, your ferritin is, the lower your dose of darbepoetin. So these two patients, this one is actually a liver patient who has massive splenomegaly and runs very low platelets and white cell count as well, and I think that's probably why we're having to drive him harder to get his hemoglobin up. And this one that's got a low ferritin and a higher dose of Darbo is a little girl who only started with us in the last couple of months, so we haven't yet managed to get her ferritin levels up to the level that we'd quite like them to be. And this is the same, shows exactly the same. Essentially, this is the dose of darbepoetin per kilo against iron saturation. So if you have higher iron saturations, you have a lower dose of darbepoetin. That's the same boy who with the liver disease, and this is the same girl. I'm not quite sure who this one is. So iron, thinking of things for the future, novel iron therapies for iron deficiency anemia. This is a paper from 2018, and this is, as I think most of the things that we do in children, this is in adults. So we wait for the adults to make their decisions and try things out a bit before we do them, don't we, generally? So this was looking at ferric citrate, and essentially it showed that ferric citrate used both as a phosphate binder and to treat iron deficiency was very useful. You didn't get any severe hypophosphatemia. They didn't seem to get side effects in the way children often do with oral iron, or people do with oral iron. They also looked at ferric maltol and sucrosomal iron preparations and showed encouraging results in non-dialysis dependent CKD. And they stated that additional trials are needed to assess the long-term effects of ferric citrate in non-dialysis dependent CKD and its role as an iron repletion agent in patients with dialysis dependent CKD. So ferric citrate might be good in the future, both as our phosphate binder and to treat our patients with iron. So this was a paper which was from 2019, and it looked at the preferential use of EPO as opposed to using intravenous iron to look to see which was best, basically. And they treated their patients according to KDOGO guidance targets with an increased dose of intravenous iron in one group or an increased dose of erythropoietin in the other. And they basically showed there was little difference in the two groups. I guess for us, iron is a lot cheaper than darbepoetin, so we tend to try and repeat our patients with iron to reduce the amount of the EPO that we use, as I've just shown you in the spot audit I did. So, excuse me, let's have a gulp of water. So erythropoietin. Erythropoietin is an amino acid glycoprotein hormone which is synthesized and secreted by interstitial cells to stimulate the production of red blood cells in the bone marrow in response to falling oxygen levels in the tissue. It was first isolated in the urine in 1977, and the gene for it was isolated in 1983. In 1984, the gene was cloned and expressed in Chinese hamster ovary, which enabled the development of recombinant human erythropoietin. 1988, the EPO alpha was first available in Europe, and 1990 EPO beta. Alpha and beta basically is a classification of the variation in glycosylation pattern of two products with the same amino acid sequence. So safety of ESAs, the most major thing I think is more applicable generally in adult medicine, but cardiovascular events, pure red cell aplasia we'll talk about in a minute. And then the other thing that you often hear quoted is malignant potential. There was a paper in 2009 which suggested there may be, and KDIGO in their 2012 guidance recommended using ESA with great caution in patients with active malignancies, particularly if you're expected to get cure. However, I think the risk of malignancy due to ESA is small, and in fact I think many oncologists actually use them to treat the anemia as a result of chemotherapy, and I think we have to balance the risks of what we're doing. So the CHOIR study from 2006 was one of three studies I think that was quite pivotal in looking at the target hemoglobin that we now use. So they looked at target hemoglobin levels of 13.5 was at that point in comparison to 11.3. And they essentially looked at the end effects of death, congestive heart failure, myocardial infarction, and strokes. And they found that these were significantly higher in the higher hemoglobin group. And from this point, the guidance I think has been built on to use the levels between 100 and 120 grams per litre. So what not to do. So NICE tells us that we shouldn't supplement with vitamin D, folic acid or carnitine to specifically treat anemia of CKD. It also says that we shouldn't use androgens to treat the anemia. And it states that in people with anemia of CKD, we should be treating the clinically relevant hyperparathyroidism to improve the management of anemia. I'm not 100% sure of the mechanism, but hyperparathyroidism, without a doubt, hinders our response to EPO. So ESA resistance, this is something that I guess with this girl that she has. It says that, this is from the NICE guidance again, after other causes of anemia such as intercurrent illnesses or chronic blood loss have been excluded, people with anemia of CKD should be considered to be resistant when the aspirational range of hemoglobin range is not achieved despite 300 international units per kilo per week or more of subcut EPO, or 450 international units per week or more of intravenous EPO. Or then it talks about Darbo, but I think you use Neuracormin, don't you? There's a continued need for the administration of high doses of EPO to maintain the aspirational hemoglobin range. In people with CKD, pure red cell aplasia is indicated by the low reticulocyte count together with anemia and the presence of neutralizing antibodies. So you do, to be able to confirm that, you do need to measure the anti-erythropoietin antibodies and know that the reticulocyte count is low. In people with anemia of CKD, aluminium toxicity should also be considered as a potential cause of reduced responsiveness to EPO when other causes such as intercurrent illness and chronic blood loss have been excluded. So the NICE guidance suggests that aluminium levels are not actually good enough to detect aluminium toxicity, and it suggests performing a dose-ferrioxamine test to look for the aluminium levels in the bone marrow to review patients' management then accordingly. And it also suggests to consider specialist referral if you think you have PRCA. So PRCA, so this is an antibody-mediated form of resistance to EPO. There were rare cases until 1998, generally associated with subcutaneous, not IV administration of EPO, and the thought is that subcut administration causes more of an immune response. I guess why we have our vaccinations subcut. In around, I can't remember what year it was, but I think it was around 2002, maybe a bit earlier, the Eprex manufacturer changed the stabilizing agent of their product from albumin to polysorbate 80 and glycine because they were worried about the potential of transmission of CKD disease from the human albumin. And it's thought that the polysorbate 80 may have increased the immunogenicity by eliciting formation of EPO-containing micelles, or possibly by interacting with the leachates, which were released from the uncoated rubber stoppers of the pre-filled syringes for subcut administration. The rates, they obviously altered how they were making their product, and by 2003 Johnson & Johnson replaced the rubber stoppers and Teflon stoppers, and essentially the rates of PRCA returned to normal. So biosimilars. So obviously erythropoietin is a great benefit to our patients, but it's significantly costly. Biosimilars, as you know, are considered therapeutic alternatives to reference biologic drugs and have to demonstrate high similarity in terms of the physicochemical and functional characteristics and their clinical performance. There have been biosimilars that have been authorized in the EU since 2007, but they're not universally being used. And the main barrier which people quote is that the lack of comparative effectiveness and safety data, as well as the lack of clinical efficiency data of switching strategies. So this was a paper from 2017, an Italian paper, which suggested that there's a comparable risk-benefit profile for the biosimilars as there is with the originators. However, there's still not widespread use. I'm not aware in the UK that we're using biosimilar erythropoietin, and like the ferrous citrate that we were talking about earlier, I think that the chances of us using these things in pediatrics before they're well used in adult medicine are small, but something for the future. So the role of blood transfusion. So this is taken from NICE, and they state that we should be referring all patients with ESA resistance to a hematology service, particularly if a hematological disorder is suspected, that we should evaluate and discuss the risks and benefits of red cell transfusion with the person where appropriate, or with their family and carer. We need to take into account their symptoms, their quality of life, other underlying conditions, and the chance of a future successful kidney transplant, in addition to the hemoglobin levels when we think about the need for transfusion. That if we are regularly transfusing someone, we should be thinking about stopping the erythropoietin, and then 1 to 3 months after stopping, looking to see whether the rate of transfusion has increased to decide whether or not to restart it. So why not transfuse people, other than obviously the risks of viruses, unknown viruses? There's a risk obviously of iron overload, which is associated with increased mortality. And as you know, there's a risk of sensitization, making future transplants difficult. So this is just to say that we, probably about 4 years ago now, one of our pharmacists has a desire to back slightly away from pharmacy and more towards working clinically, and so she started a renal anemia clinic with us, as I say, about 4 years ago, and that's up and running. She does it once a week. She sees 3 or 4, well, it was 4 patients, it's now 3 because of the COVID restrictions, and she trains patients to give diabetes, and she gives courses of IV iron. And this was just an audit after she'd worked for a couple of years, where she reported that 77% of the patients that she treated who received a 6-week course of 2 milligrams per kilogram of Venofer achieved serum ferritin levels within the guidelines. Those that were referred with a very low serum ferritin of less than 20 probably required at least 8 doses to achieve the recommended level. 94% of the patients that she treated achieved a rise of hemoglobin, with the average being 115. 50% of the patients that she was treating who were already on EPO either stopped and came off EPO completely, or they reduced their dose once they were iron replete with the intravenous iron. And she also commented that there didn't seem to be any significance attached to the number of weeks that the iron was given over. So she was doing weekly doses, and they were meant to be every week, but ended up being between 5, it took 5 weeks, and the maximum was over a 9-week period, and the results didn't seem to vary. So with my hemodialysis patients, all our hemodialysis patients get intravenous iron, and we use what we call correction courses to try and top the patients up, so they get 3 doses for a week for 2 weeks of 3 milligrams per kilogram, just to top them up, and then we keep them on what we call maintenance doses of IV iron, where they get between 1 and 2 milligrams per kilogram usually, to try and maintain their hemoglobins. So my personal practical tips, they're not groundbreaking, and I'm sure what you're already doing really. So I think it's clear from the NICE and KDIGO that actually we should be treating iron deficiency first, and if we do get adequate iron levels, firstly we might not need to use EPO, and if we do, the chances are that we'll use much lower doses, and I think iron is significantly cheaper than the erythropoietin. Make sure your patient doesn't have another cause for anemia. Make sure your PTH is okay. Looking at your case, I do wonder if you could get your PTH better, whether that might make a difference to your anemia. Certainly something we've seen before is the EPO resistance in response to higher PTHs. Remembering that if you use EPO IV, you need to increase the frequency that you're giving it, because you lose the sort of depot effects that you get if you're using it subcutaneously. I think a big thing for me is that we used to be, the way our patients used to be managed, they were, the doses changes were big dose changes. People would halve doses of erythropoietin, or they would double doses of erythropoietin. And we got very big swings in hemoglobin, but I find if we make small dose changes and try and anticipate the direction that the hemoglobin is going, I don't say we're anywhere near perfect with our hemoglobins, and we certainly get very high and very low levels, but I definitely think that it's improved. And then my other thing would be brave and try not to transfuse your patients if a transplant is a possibility. And I think your girl, I think that you had no choice, because she had heart failure and many other things. But certainly with our regular hemodialysis patients, I will rarely transfuse them. I certainly won't transfuse them if the hemoglobin is above 70. And I'm actually quite comfortable if it's a chronic patient with a hemoglobin that has sort of been lowish for a while, in working hard, giving extra doses of darbepoetin, making sure their iron is okay, and trying not to transfuse them if at all possible. Thank you for listening. That's the end of my talk.
Thank you, Susan. That was excellent, comprehensive, and you ended up with very good tips. So I think we can ask Subhankar to go to that slide of yours. Subhankar, the one where you were, yeah, the summary slide. And in the meanwhile, we will take a couple of questions. So Susan, there is one question from Dr. Vivek Maheswari, saying that he has two siblings of Joubert syndrome with severe anemia with CKD age 4. So you have, and this question is, so what is the future plan for this family? I think you have already dwelt with how to approach any anemia with CKD in stage 4. But any particular thing with Joubert, anything you want to add in extra?
No, not particularly. I would treat them the same. I would be going with my iron, trying to get my iron levels up, and yeah, no, I would treat them the same.
And Dr. Susmita Banerjee has this question, which I also have the same question. Is the maximum level of ferritin and TSAT you accept when you are increasing iron supplement? So I'll just go through one of the case which I was dealing with, I think last year or before. This was a child who was end-stage renal failure on hemodialysis, initially PD and then transferred, switched back to hemodialysis. The ESRT was from posturethral valve, and he had a ferritin consistently between 800 to 1200, and TSATs was coming around 20%, 18%, 22%, something like that. Hemoglobin was not really going up, and we were already on a EPO dose of 300 or 400 unit per kilo. So in this sort of a situation, what would you do? And our child also, if you, this particular child that Subhankar was dealing with, you see that the ferritin is quite high. TSAT here is not that low. Like the previous child had a TSAT of about 22, 23, 25, something like that. Here TSAT is about in the 40s. So one question is that, would you still give iron to this child as well as to the previous child that I was alluding? Like, what is your cutoff of TSATs and ferritin?
So this child with the ferritin that's between 800 and 1200 had a normal CRP, did it?
We did a CRP and it was on the higher side.
So I would be worried.
We did a HSCRP and that was on the higher side.
Yeah, so
but we could not find any infection. We did a blood culture also. There was no infection as such.
I mean, I suspect that your I think in that case the iron is probably high because there is some inflammation somewhere going on, because the ferritin is out of keeping with the CRP. And I think that's difficult as well, because I didn't touch on, I realized as I was doing that, there is some suggestion that we shouldn't be giving iron to people who have active infections, with the concern that you are potentially feeding the bacteria with extra iron, which they may find beneficial. So I think that is difficult. And I would in that sort of situation, if I was absolutely 100% confident there was no TB, no other infections, and it was some other cause of inflammation that was causing it, I would probably carry on with my ferritin. But I think if there was any concern at all with my iron, I think if there was any concern at all that there was active infection, then I wouldn't be giving iron at that point.
So Susmita Banerjee also put in the same point that similar to my child, her child was also not having any evidence of infection. So there were no evidence of TB. We did look at the blood cultures, everything. So in that case, but this ferritin, I don't know how much was the ferritin in Dr. Banerjee's child, but in my child, ferritin was consistently between 800, 1200, around that range. Would you still go ahead with iron, or would you
I have had,
reevaluate?
yeah, I have had odd children that I have had to run with slightly higher ferritins to get their hemoglobin to a reasonable level. So yeah, I think if I was confident there was no infection, then I would on occasion, particularly if the iron saturation was low, I would on occasion run it that bit higher. I think if your ferritin is high and your T-stats are high, I think you need to think about it, because in the longer term you might do more damage with your iron overload than anything else, and it may be
So
you're better off.
this T-sat was not low, but it was around in the 24, 25, around that, consistently.
I mean, I would personally, if you needed to have your iron higher, I have on occasion done that.
And how high you'd be happy to accept, like a ferritin? Do you have any cutoff, or you just go case by case?
Well, I would go case by case. I mean, officially, I would say we have to say that 800 is our cutoff, but I have probably probably up to about 1100. I probably haven't run them higher than that. And I guess the other thing to do then is to involve your hematologist and look at whether you should be looking for evidence of iron toxicity and doing I can't remember what the scans called of the liver that you can do to look for iron deposition and things. But I think if you are running levels like that for any period of time, I would be talking to my hematologist as well and asking for their input and advice.
So that is interesting, because we did MRI on my child. After running him on iron for some time, I didn't do the MRI. Another unit did the MRI, and that showed that there were iron deposition in the liver. So I'm now like, I was worried. Then was I doing something wrong? But then I still don't have an answer of what should I have done other way.
I think it's a balance, isn't it? And I think a lot of what we do in medicine is a balance, and you have to balance whether I guess you have to involve the families to some extent in the decision and talk to other colleagues, but I guess it's a balance to whether or not the anemia is going to cause the child more difficulty than the iron overload. And it is that, I think it's a balance.
So that comes back to this question, like, how do we treat this anemia of like chronic inflammatory conditions? Like, we all know that CKD by itself is a state of chronic inflammation, and particularly we get children like who have been badly dialyzed, has not been being following medications, following doctors very well, and they come to us with a chronic, I believe that they come to us with a chronic inflammatory state where we cannot really find any infection per se. In those sort of a situation, whether doing a hepcidin is useful or not, I do not know, because hepcidin is not easily available commercially. But also, even if I do hepcidin, how will that change my management, and what should I do in this sort of conditions?
I think in those ones you probably do have to run higher, as long as you make sure you've got everything else right and you haven't got high aluminium, you're not aluminium toxic and those sort of things as well, and you've ruled out other things. I think those are the ones that probably you will have to run a slightly higher ferritin potentially on.
So that comes to the other question of aluminium toxicity. So that is like, am I right that it is still happening even though we are not using aluminium binders?
Yeah, I think the hemodialysis patients sometimes can end up with high aluminium levels anyway. We measure ours on an annual basis, although, as I said, I think that the levels don't necessarily rule out aluminium toxicity, but we do keep an eye on our aluminium levels. They're rarely high, but we do watch them.
So, Susmita, if you have any particular point, you can unmute yourself and ask or comment.
So thank you so much, Dr. Stephens. I think that this is the really main issue, that sometimes we struggle with cases very similar to the ones Rajiv and Shubhankar have spoken about, where we feel that we are giving them adequate iron and adequate ESA, but we are still not getting on top of the anemia. And then in some occasions, we do have to transfuse them when the hemoglobin levels fall. And we always feel guilty about transfusing them. But I think there's no easy answers really from what I gather. Looking for infection, looking for inflammation, trying to correct those. Anything else? And correcting things like PTH. Some of my kids have been on ACE inhibitors, and I've tried to stop those.
Yeah, I agree. Yeah. I mean, the other thing I was saying before everybody else joined, that I think that sometimes we have to be braver with our doses of erythropoietin. And I have several patients who I have really pushed the doses of erythropoietin to levels quite significantly above what they suggest you should need to go to. I was describing a child that I have with oxalosis who I can't remember the conversion, but basically he was on about 6 micrograms. You can tell from my presentation from the audit I did that most of our children would be on half, when they're stable, on half to 1 microgram of darbepoetin per kilo, and this particular boy was on 6 micrograms per kilo of darbepoetin, enabled to stop us having to recurrently transfuse him. But actually it did work, and those much higher doses of erythropoietin did get him with a hemoglobin transfusion independent. And what I've found is that over a period of time, that as he's had a liver transplant where he's actually on home nocturnal hemodialysis 6 days a week, and over time his oxalate levels have come down, and over the last couple of years his requirement has come down from 6 mics per kilo to 3.5 mics per kilo. So with time we have managed to improve that, but he's still on a massive dose in order to maintain those levels. So I think sometimes my other tip, I guess, is that sometimes and he's not the only one. We had a little girl with Down syndrome who had very resistant anemia, who was very dependent on transfusions, that actually when we pushed her erythropoietin doses very high again, we actually did manage to get her with hemoglobin levels that were over 10 and transfusion independent. But yeah, so sometimes I think I go much higher with my erythropoietin than it might be recommended.
And so Rajiv asked about darbepoetin next. I think many people in India have used it, but I think in Calcutta we haven't started using darbepoetin. Do you find it very much preferable once you start using it to erythropoietin? And what kind of doses do you start with?
So to be honest, I'm not sure it really makes any difference which you use. I think we switched as a unit to darbepoetin, not so much for the hemodialysis patients, but more for the PD and the CKD patients, so that they had to have doses less frequently, essentially. And I think that was our sort of main reason for switching. I think I don't have a strong feeling about darbepoetin rather than neorecomin, and certainly it's difficult to get doses small enough for neonates and things, so we still would use neorecomin for some of the smaller babies. So I don't think it's particularly that much better. It's just now, having used it mostly for most of the last 10 years, it's now what I'm used to using more than anything else.
Any difference in hypertension between the two?
Most of my hemodialysis patients, once they're established on hemodialysis, have very little need for antihypertensives. It takes some working, and some of them have quite a lot of need to start off with, but then once they settle into hemodialysis, they might end up perhaps on some amlodipine or something. So I don't think there is much difference between the two.
You spoke about losing the depot effect when you're giving the ESAs intravenously rather than subcutaneously. So when you're using darbepoetin intravenously, how often would you usually need to give it in a week?
You usually give it once a week, Erythropoietin. They normally have it. It varies. The kids on CKD and with PD vary anything between once a fortnight to once a month with the Darbo. Most of the children on hemo, I find, if you don't give it once a week, you basically lose its efficiency, and you end up with hemoglobins dropping. So mostly it's once a week.
Thank you.
Very occasionally, if we've got a hemoglobin that has drifted down, and occasionally things that you might miss that you haven't restarted the Darbo, having stopped it because they've got a bit high, and they've dropped down. Occasionally, we might give it twice a week just to give them a boost to get the hemoglobin back up again. But certainly for maintenance, almost all of them are on once a week.
So, Subhakar, if you can again make this full screen and while you are doing this, one more question we had was your regime for iron therapy that you use for your hemodialysis.
Yeah, so they're basically, when they start on hemodialysis, if they're not iron replete, then we would, and if the iron levels drop low during the treatment, then we give what we call a correction course of IV iron, which means that they get a dose for each dialysis session, essentially. So 3 times a week, iron at 3 milligrams per kilogram for 6 doses. And then they all go on to a maintenance intravenous iron dose of usually between 1 and 2. We'd start them off perhaps on 2 milligrams per kilogram once a week. And then most of them have, as you can see, most of them have pretty good iron levels. And sometimes we have to reduce it down to 1 milligram per kilogram, but they all get maintenance IV iron.
And in your unit, so you are going with ferritin TSAT, or you are going with the reticulocyte, like the...
So at the moment, we're still using ferritin and TSAT, but we are trying to get our labs on board because the NICE guidance is that we shouldn't be using that if we can avoid it. So we are trying to get the labs on board to look at hyperchromic red cells and hyperchromic red cells essentially. But it's interesting. Once or twice I've got the lab to let me have the results that they say they're not really supposed to publish because they're not accredited. But actually the hyperchromic red cells, if I'm interpreting right, all seem to be fine. But then I guess my patients generally tend to be iron repeat.
And is it all because, like, if we go we are now avoiding the inflammatory component? Is that why NICE has given this advice?
I think NICE would say they've looked at the evidence and they think that it's a more reliable way of judging iron deficiency, looking at the hyperchromic red cells than using TSATs and ferritins.
But then that comes to the another question, which might be an idiotic question. But suppose if we stop doing ferritin and TSAT, and if we just go with this hyperchromic red cell or this reticulocyte and neohemoglobin thing, then we might be missing this high ferritin, and will be more chances of iron overload, or?
No, yeah, I think you still, I think NICE would say, the NICE guidance still suggests you still have to measure ferritin intermittently to look, not so much the TSATs, but the ferritin intermittently to make sure that you keep your ferritin levels, they say, below 800. You can't get rid of ferritin.
But by your clinical practice, and I believe there was one RCT also done in the adult, which had said that a slightly higher ferritin can be acceptable. Ferritin
800 is the level that has been taken by KDIGO and NICE as the cutoff. But we certainly, as I say, we have run odd children higher than that, and I think we just have to use our clinical judgment, don't we?
So going back to our child, what do you think was happening? If I, after listening to your talk, one thing might be that the PTH was quite high. And,
I would be working on. Is your normal what's your aim for PTH levels? I don't know if the units are the same.
Yeah. So our normal, completely normal, is 80, around 80, And if we go by 5 times the normal, it will be about 400. So we did start with a very high PTH, 1650, and now we have come down to about 510.
I would try and get that really tight myself. If I was really struggling with this child, I would be really trying to work hard to get my PTH down further. Do you use calcitrol?
We have discussed this a number of times, that whether we should start using calcitrol in this child or not.
I would.
Me, Subhankar, and Dr. I think Susmitadi also said that.
Yeah, I would. It often makes a big difference in the children we really struggle with. It's a pain in the backside, calcitrol, because it only comes as capsules. You can't get liquid forms of it, which is often difficult with the kids. But your little girl looks like she might be old enough to take capsules, but I would go with some calcitrol.
No. I thought that sorry, I was thinking you were mentioning about cinacalcet. No, this child is on calcitrol. Is on oral calcitrol. Yeah.
How much? Doses of this is like 2 tablets, 0.5 microgram per day, every day. She's taking calcitrol.
So he's on calcitrol, but we were thinking of cinacalcet or something else.
What sort of calciums does she run?
Calcium is around how much? About 8, no? 8 milligram. And so calcium was not a problem with this child, but not very high, about 8 or 9.
I don't know what that is. That would be very high.
That will be I think about in millimole will be about 3.2, 3.5.
Quite high then. Yeah, I'll go for cinacalcet then. Give cinacalcet a go.
Because this ferritin continues to be on the higher side. And
is she on iron?
No, we stopped iron for a long time. Almost around May, June, we have stopped iron. But the ferritin continues to be on the higher side. TSAT also continues to be on the higher side.
You see, that's also odd, isn't it? She's about a year. So, and her CRP is normal, is it? I think I saw.
Subhankar, the CRP was normal, no?
CRP is normal. So, you did mention that the HCRP is high, but the CRP we used to do in that's normal. Even the procalcitonin also normal, and we did repeated blood culture. There is no clinical sepsis or infection, and that's all actually. So my question is here that. Okay, my question is that if there is no feature of clinical or laboratory sepsis or infection, but the ferritin is still high, like more than 2000 kind of things, and iron saturation here is high because of the child is getting transfusion, but if it is TSAT is low, like less than 20, as sir is mentioned previously, the ferritin is high. TSAT is a bit low, and there is no feature of sepsis or infection. So, how long you wait for to come down the ferritin, and when you decide to start iron?
I would be talking to a hematologist, to be honest. I would be very uncomfortable with the ferritin levels like that, and I don't know why they're as high as that. I mean, they're massive, aren't they?
We have spoken to the hematologist, and they said do a bone marrow, and that was not really helpful. So now we are just keeping our finger crossed, hoping that if we are able to transplant, then the mother kidney will be able to sort out all her problems.
Why did the hematologist think her ferritin is so high? Because that's not iron therapy that's done that. You're not going to have iron therapy that gives you ferritin levels like that.
And we have stopped this iron for more than now 9 months, almost 8-9 months.
And she's on hemodialysis, so she's going to be losing iron all the time. So I think that's really odd, and I would be going back to my hematologist and saying, I really don't understand this. Can you help again? I think it's very bizarre.
Bone marrow iron staining did not show any iron overload.
Yeah. Yeah, yeah. I don't know. I mean, those ferritin levels are massive. And I don't think you need to. You've got a high iron stat and high ferritins. It would be interesting to know what hyperchromic red cells were, but it's hard to think that if you've got such high iron stats and such high ferritin that she is iron deficient, isn't it?
One last question had come, like when do you start EPO? Like in the standard, like do you have a cutoff of 10 and any 10 below you start EPO, or you are more flexible? If the child is doing well, playful, then you wait till 9.
So we would go with trying to make sure that iron repletes first, but actually we would start EPO when their hemoglobin was going down towards 10. We would try not to let them go down below 10, so that we might actually start when they were like 10.2, 10.3 to try and maintain the hemoglobin before it drops.
So once it is around 10, you start the EPO, provided we have corrected everything else.
Yeah.
Thank you very much. We have been keeping you for a long time. Any other question by any of the panelists or the attendees? If there are any question by the panelists, you can just unmute yourself.
I agree. I think the ferritin is more likely to be reactive. So I was looking at the chat.
Question for you. So I have a question, sir. Do you use hepcidin for diagnosis in this situation? Functional identity.
So you are breaking up, Subhankar, but you are breaking. Subhankar, you are breaking off, but I think I understood your question, so I'll just repeat it for Suzanne, that he wanted to know about use of hepcidin in clinical practice. Like, do you use it? No.
No.
And
that was a short answer.
Yeah, and I just in with one anecdotal experience of mine, and this is something that I have raised it in number of a forum, but I had a child. It was like almost 7-8 years back, who came in, who was like this only, like on ESRD, on PD. Everything going bad, high ferritin, TSAS was also on the slightly higher side, but the hemoglobin not going up, and we ultimately found out this child to have a pure red cell aplasia. And we stopped the EPO and started the child on steroid. We gave it for about a month. And remarkably, after that, his EPO requirement definitely improved. But what also happened was that he put on weight and everything also. He was having severe anorexia that sort of disappeared. Maybe some of it was before, maybe because of like his hemoglobin was getting better, etc. But then some of it, I think, might have been also because this steroid sort of suppressed the inflammatory state. So I am always thinking that in such sort of situation, whether steroid will make any difference, a low dose steroid for say a week or 2 weeks, but I have never been brave enough to try this. Like in this sort of a high inflammatory CKD situation where we have sort of rolled out all infection, whether a steroid will be of any use. But I've never been brave to try it.
What's the ESR? What's the ESR?
ESR was it's a long time back. I don't remember. But
what about this girl?
In this girl, Subhankar, have we done a ESR? I think we did a ESR initially.
Normal. It's not so high. Initially, it was high because of the infection at the time. It's not so high. I mean, like it's a higher normal range, but I don't remember.
I think last I remember was around 30-40.
Yeah, which is in someone that's anemic and with renal failures really is about normal, isn't it, for them? It's not really significantly elevated. I don't know, it's very difficult, isn't it? It's always when you're giving steroids blindly and you don't know that there isn't anything effective going on.
Exactly.
It's brave.
But I just like from the hypothesis point of view, we are dealing with a highly inflammatory state from CKD. If we are dealing with that, will a steroid help or not? But I've never been brave enough, and nobody has supported me also till now.
How much is she dialyzing?
Now we have come down to 4 times a day, 4 times a week.
4 times a week. She's got adequate dialysis, hasn't she?
Yeah.
Yeah, I think, no, I don't have any great wisdom for you, I'm afraid.
No, we will, I think, look into the PTH aspect, as well as we will try to look into those hypochromic RBCs and all. I think it is done in India. It is some labs are doing that.
And then how many units per kilo of EPO is she on now?
She's
now
around 330.
Push it up a bit. Be
so
brave.
we can go up. Yeah. That is the third thing we were planning to do. Go up on the EPO to around 400, 450 at least, and then
I would push it. I would definitely push it.
Because her blood pressure is now under much better control. In fact, we did a 24-hour ABPM, which was showing normal blood pressure.
Yeah, push your EPO, get your PTH right, and then see. But it's difficult. There's something funny going on with her though, with her ferritin, isn't there?
And we will again have a word with the hematologist about this ferritin thing. Okay, thank you very much, Susan.
I am married to a hematologist, so I did get him to have a look this morning to see if he could come up with any pearls of wisdom, but he didn't really, I'm afraid.
Yeah,
but he is an adult hematologist.
Yeah, but unfortunately, I am not married to a hematologist, and none of our colleagues are. And we have to run after we have got one hematologist in our center, but she comes about twice a week, so we have to run after her. Okay, if there are no more questions, I'll not hold you any longer. But again, really, really thank you from all our team.
Thanks a lot.
Thanks for inviting me.
Thank you so much.
It was definitely useful. Thank you very much. Thanks everyone for joining. Bye. Bye.